Hello everyone, my name is Andy and I am the nurse with the This is the next in a series of educational videos on medical and nursing topics. I was requested this week to do a video on hospice care. Remember, these videos are optional, but I try to provide you with worthwhile material that you can use in your career as caregivers. Please feel free to send me ideas for future topics. So hospice care, a lot of people actually think this is almost a bad word or a death sentence, but in the medical community, we like to think of it as a care plan that focuses on making a person's life more comfortable and enjoyable. Now, I don't want to sugarcoat the idea of hospice either. Hospice, almost always, is a care plan for those who are considered end of life. However, these people that are placed on hospice care, there are people that are placed on hospice care and then they do come out of it. Now, we all know that none of us will make it out of this world alive, and none of us probably don't know that we will live forever in our earthly bodies. So ask a rhetorical question. If you were given 6 months to live and there was absolutely no chance of survival, how would you want to spend your time? For me, I'd like to be on a beach in the Caribbean with sun and fruity drinks and delicious food and my loved ones surrounding me, and even perhaps a few sexy firefighters. I don't want pain, I don't want anxiety, I don't want loneliness. I am sure most of you would have your own idea of what you would want, but I would highly assume that we would not want the pain, the anxiety, or the loneliness. I would also ask, if you were terminal and there was no chance of survival, would you want to be poked and prodded and sent to the hospital every time you had a fever or your blood pressure was a little high? I would guess the answer would be a resounding no. No one wants to spend their last 6 months in the hospital bed getting pumped with antibiotics. So the whole focus on hospice is to give the person the best end of life possible without pain, anxiety, loneliness, difficulty breathing, nausea, discomfort, constipation, or agitation. Everyone that enters hospice does have a plan tailored to their needs and desires, so everyone is different. But the focus is on giving them a comfortable experience and letting the body take its natural course and not doing much on any historic measures such as CPR or intubation to prolong their life in an uncomfortable way. So what is the whole idea of this 6 months? First of all, it is not set in stone, and we don't want to just leave after 6 months or discontinue their hospice care after 6 months. 6 months or less is generally what healthcare professionals will deem a person has left on their life. But there are some that will last much longer. We also have to realize that unlike most of us, those going on to hospice have accepted their fate and have generally been in pain and suffering and anxiety and are really ready for this next chapter. We cannot be afraid of hospice, but rather understand it and know that your resident on hospice is probably ready to be comfortable and ready to leave this world. So what does hospice generally look like? Well, we focus on comfort. We generally discontinue a lot of obnoxious medications that may cause side effects and only do minimal benefits such as blood pressure meds, cholesterol meds, diabetes meds depending on the person's blood sugar numbers. Remember, we don't want to kill a person. We just want to take away some bothersome things and let nature take its natural course. We often will discontinue the checking of vital signs, blood glucose levels, or other lab draws such as thyroid levels or liver function tests. If we aren't going to try to artificially prolong the person's life, and if they are ready, let's get rid of these bothersome interventions. We will often stop all or most of the hospital visits and most of the time make the person's code status as a do not resuscitate and do not intubate, which means that we will not crush their chest to perform CPR or shock them to restart their heart, or we will not place a tube in their lungs to help them breathe. However, as I stated earlier, every situation is custom designed to the resident. Next, during hospice, we really focus on pain management. If a person has less than 6 months to live, we are not worrying about them getting addicted to pain pills or dependence on opioids. Most of the time, hospice candidates will receive a liberal amount of a PRN and, as needed, opioid to keep them comfortable. This is a little bit of a sticky issue since we do not want to cause them more complications such as constipation or the potential for respiratory failure due to central nervous system depression that opioids can cause. If your resident is going to be going on hospice, please clarify with a hospice nurse or doctor if Narcan should be administered in the event of an overdose. Remember, we want to keep them comfortable, not kill them. Also, using Narcan on somebody that has had a hefty dose of opioids during hospice can bring about very hard withdrawal symptoms such as vomiting, intense pain, tremors, and even seizures. Another issue that we have to deal with on hospice is the potential for constipation. On all of the opioid medications, one can become constipated very easily and thus can have a lot of pain related to this constipation. Be liberal with giving the PRN laxatives and keep a close eye on their elimination record to make sure that constipation isn't causing them more problems. I oftentimes will give a PRN Senna or Senna S to somebody every time I give them a pain medication, if allowed by the MAR. Other common PRN medications for a resident could include anxiety medications such as lorazepam and medications for hallucinations, agitation, nausea such as haloperidol. You'll probably see a medication called icosapine, which is used for excess secretions. When somebody is dying, they can often produce a lot of saliva and can choke or drool, and this is very uncomfortable. Please use the icosapine as prescribed to help them with this. In addition to the new medication changes, residents at hospice will get scheduled extra nurse or aide visits, chaplain visits, massage visits, music therapy, pet therapy, whatever they may desire to make their end of days the best they can. If they are on certain aphasia diets where they have trouble eating certain foods, if they don't want to do that, they don't have to. If they want to eat whole foods, they have the right to do that. So most importantly, if your resident is on hospice and they are in pain, they are wet, they are nauseous, they are anxious, they are lonely, they are constipated, uncomfortable, agitated, it is your responsibility and job to make sure that they are not any of those things to the best of your ability. Your person is at your resort, your hospice resort, and you are to treat them as if they are at your resort. Thank you much for watching, and enjoy your week.